Hello, everybody, and thank you for joining. Jason just put a reminder into the chat box there to mute your microphones and that this presentation is being recorded, so just a heads up. If people have questions throughout the presentation, feel free to type them into the chat box and I'll kind of moderate, but we'll have time for questions at the end for the group. And so you can hold on to them and ask verbally or put them into the chat if you don't want to forget them, and then we can address them near the end of the presentation. For those of you who don't know me, my name is Jackie. I'm a pharmacist with the Opioid Stewardship Program, and we're really lucky to have here, I'm running IT as well. We're really lucky to have four pharmacists from the Medication Assessment Center's newest initiative, their interprofessional opioid pain service, based out of Saskatchewan. And so they're here to talk to us about the program, how to refer to the program, and the value that they're adding to the province here. So I will let Anand, Taylor, Amy, and Kelly take it away.
All right, thank you very much, Jackie, and thanks everyone for having us. So first off, I do apologize for not having my video on. It's just my computer tends to freeze when I do that. So my apologies about that. So our presentation today is called the MAC iOPS, a novel approach to chronic pain management. So joining me in the presentation, I'm the project manager for MAC iOPS. I'm also a community pharmacist by practice. With me as well are Taylor Raish, Amy Weeb, and Kelly Kislick. The three of them are clinical pharmacists with MAC iOPS, and they'll be presenting with me today as well. So again, thanks so much for having us. So first off, after Jackie mentioned, the MAC iOPS, which is, I guess, short for the Medication Assessment Center Interprofessional Opioid Pain Service, it kind of came out of the Medication Assessment Center, or the MAC, which some of you might have heard of. So the Medication Assessment Center, it's a pharmacist-led, which is housed at the College of Pharmacy and Nutrition. Pharmacists that partake in the center, they ensure that medications that patients take are safe and effective, necessary, and appropriate. As part of the MAC, there are three different services. There's the MAC service, which helps patients manage chronic medical conditions by doing what's very similar to a medication review, to put it very, very broadly. We also provide CBT therapy to help patients with sleep problems. And then the newest initiative is the MAC iOPS, which is particular to patients that have chronic pain and or are taking prescription opioids. Now we're going to talk a little bit more about what the MAC iOPS is, which is kind of like a branch of the MAC, or the Medication Assessment Center. As mentioned previously, it's short for Medication Assessment Center Interprofessional Opioid Pain Service. We launched March 2nd, 2020, with funding from the Health Canada Substance Use and Addictions Program. The MAC iOPS primarily delivers individualized patient-centered access to chronic pain management for patients in Saskatchewan. Our team consists of pharmacists, so with us today are Amy, Kelly, Taylor. Eric is another one of our pharmacists. We also have a family physician with a chronic pain practice, and we're supported by a research team and administrative support staff. So the MAC iOPS, we can kind of look at it as filling a need in our community, as many of our pharmacists will discuss coming up. We provide access to specialty we fill a need in the community by helping to access specialty pain clinics in Canada. We know how that's very limited and the wait lists are very long. We also know that Canadians are the second highest users of opioids per capita in the world. And the rates of opioid-related hospital visits and death have been increasing steadily in Canada. So MAC iOPS will primarily offers pain management, opioid tapering services, as well as educational services, which are currently provided by specialist physicians in chronic pain clinics. The MAC iOPS does not replace the existing specialty pain clinics that we have, but basically what we're trying to do is increase access to the certain services that they offer. MAC iOPS is also an innovative approach. It involves referral to a pharmacist-led program, which will then be responsible for providing patient care. The family physician involved in our team, they collaborate remotely with the pharmacist and the referring provider. And MAC iOPS will avoid the need to refer the majority of chronic pain patients to a specialist physician by taking advantage of the pharmacists that we have and their expertise, who in turn are collaborating with a family physician that has a specialty in chronic pain. So MAC iOPS services, so we have two distinct services. So patients can, so I guess it could be one or both of the services involved in patient care. So we have the individual patient consult with the pharmacist and or a case conference. The individual patient consult is very much like a medication review, and it occurs with one of our specialized pharmacists in chronic pain or opioid use. The case conferences occur on Mondays, and these include our pharmacists, they include our family physician, and any other health professionals caring for the patient. If the patient would like to be involved in the case conference, they can be invited as well. So now I'm going to go over our referral process a little bit. So I'd highly recommend that you visit our website. So it's usask.ca/pharmacist. So once you go to our website, this is kind of a screenshot of what you will see. If you click on the green button to the right where it says refer, you have the option of referring a patient. Patients can also self-refer themselves to our services. So there's one or the other. And then under the health professional screen, this is where you can find a little bit more detailed information about our referrals. Now, before COVID struck, we were making it a requirement that patients have a urine drug screen and or MSK and neurological exam to be completed in order to process a MAC iOPS referral. Because of COVID, we are no longer requiring that. So if you're looking to refer a patient, definitely don't feel like this is necessary in order for the referral to be processed. Also, as far as the referrals are concerned, I'm just going to move forward here. So this is a referral form that you can fill out online through our website. I will assure you that it is your information and the patient's information is going to be safe. We're definitely following like HIPAA with regards to this. So this is one option, is to go to our website and fill out the referral form online. And then we would receive this referral and process it accordingly. Okay. Now, how can we help? I'm going to pass things along to Kelly. So Kelly, it is all yours.
All right, thank you, Annan, and thanks to Jackie and the entire stewardship team for having us. Taylor, Amy, and I thought that the best way of showcasing our services would be to take you through our process and highlight some of our early experiences in the program. And so we're going to walk through our appointments initially. So as Annan mentioned, our program has been up and running officially since about March, although I'm sure that everyone can appreciate that our original plans changed because of the COVID-19 pandemic. Originally, our plan had been to meet people referred to our program in person with telephone, or with telephone and video services used in situations where people would not be able to come. We have clinic space at the University of Saskatchewan, and so that was our plan for hosting our appointments. Because of the pandemic, we moved all of our services to a virtual platform. And once again, I'm sure that many of you can appreciate the work of moving to an entirely virtual clinic. We did initially take some time to regroup and make sure that our process and procedure was ready to go, but we did start seeing clients again in late April and early May. Now, anyone that's been seeing patients virtually during the pandemic can certainly relate to many of the challenges and opportunities that this new way of doing business has presented to us. Certainly, access to technology and ease of use can be challenging for many of the people referred to our program, and possibly even for a few of us, like me. But our experience has been that the majority of our appointments are actually phone call appointments, and few people are using video conferencing. Obviously, we don't have data to officially present at this stage. We're only a couple of months in. So the numbers we're speaking today are really just our observations. But personally, I've probably seen about 90% of my clients over the phone, and with just a handful of them using video conferencing technology to meet. With the challenge of a phone call comes the issue of having to use words to describe and explain everything, then rather than having a handout or some other sort of visual tool to help you with communicate. And assessment can be quite difficult when you're unable to visualize the person that you're speaking to. So certainly there are some gaps in our assessments in not being able to connect via video. A limited technology can also be a barrier when you're providing education tools, and we've certainly found that in our practice. We've had to make much more use of traditional mail than we may have had to in the past, and sending out some of these tools and resources in paper format rather than using some technology. In terms of uptake, we've actually had an excellent response from people that have been referred to our program in terms of in-person versus virtual appointments. And almost all of our clients have really embraced this change despite a few hiccups in terms of technology. Having said that, we are currently in the process of trying to get at least a day or two for in-person visits at our clinic space at the University of Saskatchewan. And although access has presented a few challenges, I think it's also been a really significant opportunity for our clients. We are able to access people that live throughout the province, including urban and rural clients. Particularly people that are living with pain often have mobility issues and other physical challenges with getting to and from appointments. And these barriers all seem to be lifted with virtual care. So I think that although access is challenging, it has been a big win for us and a significant opportunity for our clinic. Next slide, please, Anand. So who are we seeing? As Anand mentioned, our program accepts referrals for Saskatchewan residents with chronic pain that may or may not be taking prescription opioids regularly. So our focus is on helping people manage chronic pain and ensuring that the medications that they're taking are safe and effective. Our criteria for referrals is fairly broad, and we have certainly seen a wide range of people in our clinic. So our demographic is very diverse, and I think it really demonstrates how indiscriminate pain is. Recognizing this opportunity as being a chance to speak to some of our potential referrers, we wanted to speak to some of our experiences so that you as referrers can make possible considerations when referring patients to our program, as we've certainly seen some early determinants of success in our program. So our referral form, you can see there, does request a reason for referral, which is typically completed with a pretty vague response, and generally takes a little bit of a deeper dive and more investigation to dig deeper than what is actually provided on that form. So the majority of our referrals at this point have come from physicians and nurse practitioners, but our experience has been that a lot of these referrals, although they came from the physician or the nurse practitioner, have actually been made at the request of the client. And the usual reason for request on our referral forms is chronic pain, medication management. So like I said, some pretty generic reasons for referral. But in our experience, we have seen clients that come to us because they want change. We've seen clients that have come because their primary care provider wants change. We have seen clients that have faced significant stigma in accessing healthcare in our province. We've seen clients and healthcare providers that are just checking a box, meeting a need, and we've seen clients that are facing some significant harm. And I think that each of these situations presents very unique opportunities for education and safety measures and recommendations. So it's good to have that kind of information when a client is referred to us. And really, the reason for referral really helps us in starting to nail down the goals of care. And that's a really important part of our program. And Amy and Taylor are going to speak to that. So really, any additional insight that is provided to us in the referral process is extremely helpful in taking the next steps with these clients that we're seeing. Another early finding and important piece of our referral, sorry, and then you can flip back, is the importance of relationships to our programs. So our program doesn't prescribe, and it's essential that we have a relationship with the primary care provider. And there's certainly a lot more communication and back and forth than maybe the norm for other referral programs. So that relationship is really important. Also, the relationship between the primary care provider and the client we've noticed that that's important as well too. So a really open line of communication there as well. At the end of the day, this work requires really close collaboration. And an early step that we take with our referrals is to establish these relationships early on. So clear reasons for referral and a collaborative relationship certainly impact trajectory within our program, has been our experience to now. And now I will pass it along to Amy, who is going to speak to our assessment process.
Great. Thanks, Kelly. Hi, everyone. Amy here. Thanks to all of you for tuning in today. I was hoping just to build off of what Kelly has been describing and spend a few minutes going through with you what our assessment actually looks like when individuals meet with the pharmacist. For the first time, but sometimes, as you'll hear, going into second appointments as well, as we attempt to be very thorough in gathering the history, learning where somebody is coming to us from and what their pain experience has been over time. So obviously this takes a fair bit of time, which is something that we're very fortunate to have. Many practitioners in their busy clinics don't have time to actually sit and go through all the detail. So we're certainly grateful that we have that opportunity. As Kelly had mentioned, certainly one of the assessment pieces that we're lacking right now is the physical assessment, but I do think that we do have many strengths in our program. We start off with the referral information that Kelly was describing. And if the clinician has given us a hint as to what they want us to focus on, that's certainly the place that we start from in terms of establishing what the clinician's goals are for referring the individual to our program. We try our best to get as much information ahead of time that we can through the eHealth viewer, looking at prior investigations or consultations that have been done, and then also reviewing the pharmaceutical information program to see what kind of medications have been filled, what's the fill history, how many prescribers have been involved in the recent past. Then what we've done is we've put together an intake package, and it's actually ended up being a fairly comprehensive booklet, I would say. It's 14 pages, which certainly we've had some individuals say to us how daunting that is to, if they're not doing it online, if they're doing the actual paper, to receive that package in the mail and think that they have to go through all of that at one time. So the benefit of doing the intake package ahead of time is that people can work through it at their own pace. It's a low pressure environment. They can make sure that they can focus in on the questions that are being asked. And so ideally, we ask that people complete that ahead of time before we meet with them for the first time. We do try, however, not to make it a barrier to receiving care. So if individuals are not feeling up to completing the entire intake package, it is not a requirement that they must fill that out before we see them. Some of the initial pieces that we attempt to gather in there are just basic demographic pieces. We try to get a sense of what the social history is, whether or not they're employed, and then we do incorporate a number of assessment tools into that document. So first and foremost, we're wanting to gather history around the type of pain that people are experiencing, whether it's nociceptive, neuropathic, nociplastic pain. We do have the scoring tools, the DN4, which I won't say, well, it's the douleur neuropathique, and I'm not French, so don't hold me to that pronunciation, but that's for assessing the neuropathic pain. And then we also have the central sensitization index that we use for assessing the nociplastic pain. We ask everyone to go through the brief pain inventory so that they're describing to us what the pain severity is and best and worst days and average, as well as describing the interference that that pain has in their daily function, because function is a primary focus of the assessment piece in terms of what can people do, what do they want to be able to do, and what can we help them to be able to do in terms of our goal setting moving forward. The mental health component is certainly relevant and significant, so we ask people to complete the personal health questionnaire to assess or to screen for depression, as well as the anxiety disorder, the GAD-7 screening tool in order to assess for anxiety. Another piece that it was felt was very important to include as an assessment tool is the pain catastrophizing scales, that we can get a sense of how people are thinking about their pain and how that influences the treatment planning moving forward. The problematic opioid use is screened for individuals who are on opioids. So every individual on opioids is asked to complete the prescription opioid misuse index as a screen for identifying where there might be issues with problematic use. And then primarily that first appointment. So if we need to go through the intake package with people at that first appointment and go through all of those things that I just listed, we will take the time and we will do that. But ideally, if we have that information ahead of time, then we can really focus that first appointment on getting the narrative history from individuals. Certainly for our sake, it's helpful to hear the words that people are using and the approach that they're taking to their pain. But I think it's also therapeutic in and of itself for people to be able to feel as though they're being heard by a clinician, as well as to hear themselves and the words that they're describing and even the change talk that they're using, whether it's, I want to be able to do this, or I'm thinking I might want to do that. So that's a springboard that we use to move forward. And all of this then comes back into what Kelly was also describing, the importance around relationship building and rapport building. So we know that, the ideal is that we won't be making recommendations for change unless we've established a relationship with people and they are on board to also make that change. So assessing where people are at in terms of the stage of change and working together with them to make a plan for moving forward. Ultimately, it all comes back to goal setting. So we consider the clinician's goals, but first and foremost, the person or the individual that we're meeting with comes first. So we're asking them questions at the beginning and sometimes probing a little bit to get to what is it that they want to be able to do. So taking a step back from, this scenario where people are saying, I just want to get rid of my pain, to more focusing on what are the day-to-day things, being specific and achievable that people want to be able to accomplish. Next slide, please, Anand. So we take a 3M approach, keeping in mind that we want people to be thinking about how their mind, their movement, and their medications are all influencing their experience of chronic pain. Being pharmacists, obviously, we take a medication focus. That's our area of expertise, so we're always very clear about that from the beginning. But I do think who better to explain to somebody the limitations that medications have by themselves for managing chronic pain than a pharmacist. So we can help with the expectation management and the encouragement to engage in non-pharmaceutical options for chronic pain management. We also emphasize safety, so we do a comprehensive review of any adverse events that people might be experiencing, but then also safety planning for the future. So everyone is asked whether or not they have a naloxone kit, but the other thing we've learned even over and above that is not only do they have it, do they know how to use it? Does their significant other know how to use it? And has it expired in the time since they got it? So that has also proven to be a valuable component, is to make sure that that safety piece is in place. We collaborate with the physician on our team, as was previously mentioned. Most of our cases at this time we are bringing to her to kind of discuss, and I think particularly the angle that she brings to the team is the element of making sure that there's been a comprehensive diagnostic evaluation, that there aren't pieces that have been missed or that could be pursued, to make sure that we're taking a holistic approach to the care management. So all in all, we attempt to be flexible and to try and reduce barriers. We know it's not a quick fix. It often takes more than one appointment, even just to get to the point of thinking about what the plan will be moving forward. It's not one size fits all. We have to think about what the individual's goals are and what they want to be able to achieve moving forward, and also how open are they to making changes moving forward. And we also recognize that there's day-to-day variability. So what someone's pain scores are today might be different tomorrow. And we need to take that into account when we're meeting with people and helping to develop the treatment plan. So with that, I will pass it over to Taylor. We can advance to the next slide, and she's going to take you through what some of our contributions to care end up being.
Thank you, Amy. So a great segue, really leaning in here into what our contributions to the existing care team are, as we recognize that people living with chronic pain often have a large team of supporters behind them, even if that's been, transiently along the way, that these people have often been involved and had touch points with the healthcare system at multiple points. So really integrating not only the person or individual's goals, as Amy had mentioned, and framing the treatment plan around that, as well as the referring providers, but taking into account all the collateral information that we can gather, as Amy said, from our initial assessment, from those providers who are also currently involved in the client's care or have previously been involved. And sometimes that includes collaborating with community providers like community pharmacists who have information at the interface of care when they're seeing people in the community, picking up medications, discussing medications with them. We often also collaborate with psychiatry. As you'll see in a coming slide, we have a dedicated referral process to an individual who can help us with those assessments, and therefore integrating those assessments into the treatment plan as well. We do have several clients who we've seen who have had home care supports or supports through CPAS. So those individuals that are involved in this person's care and their day-to-day life also provide extremely valuable information for us to make these treatment plans as person-centered, realistic, and achievable as possible. So some components of the treatment plan include a lot of pain education, and that's really where we start with the majority of our patients as a blanket. We do know that pain education can even change the way that people have pain perception and therefore their pain management without adjusting medications or anything else, just being more informed about how pain can affect the rest of the body in terms of central sensitivity and the like. So really, we do focus a lot of time in our subsequent follow-up appointments on pain education. And a lot of the time it is multimedia as well. So being in the setting of the COVID-19 pandemic, we do communicate securely via email with clients as well to provide them videos. We give them links to online self-management programming that have been available in well-established clinics and programs for quite some time in other provinces to begin working through in order to really round out that pain education piece as a baseline. I've already mentioned how community connections in terms of other care providers are in existence in terms of us being able to make sure that our treatment plan is comprehensive and as person-centered as possible. So those really do influence how we proceed. And in terms of follow-up, those relationships, as Amy mentioned, really do play out in terms of follow-up and making sure that we're really watching these people closely and supporting them in terms of what they need. And as my colleagues have mentioned, there's been some early challenges noted along the way as well. And really, I think in response to that, our treatment plans are dynamic. So we know that people living with chronic pain come to us all along the spectrum of stages of change. So sometimes that includes motivational interviewing as a very first step along with that pain education to figure out what their motivators are and really move them along those stages of change towards action and starting to make some changes in terms of medication, mind, and movement strategies that can improve their pain perception and overall function and quality of life. And within the setting of the COVID-19 pandemic, I mean, it goes without saying that access is a barrier for a lot of people. So as we'll see in the next slide when I speak about referrals briefly, really getting access to physiotherapy, occupational therapy, some of those services have been moved online, and we've had to be a little bit creative in terms of how we connect folks with those services. And as Kelly mentioned, you know, not everybody also is comfortable using technology. So we've certainly tried to manage and modify as best as possible to really fit the needs of the person and meet them where they're at. One of our deliverables in terms of going back to referring provider and other prescribers or important primary care providers who are involved in the patient's care ongoing involves a summary letter or a consult letter, as many specialty clinics will provide. So we do provide a summary of the information we've been able to gather through the intake package, as well as those initial assessments that, as Amy mentioned, sometimes do span more than one appointment. And in that consult letter as well, we do round it out with recommendations, really looking at the big picture and taking that 3M approach, as Amy mentioned. So our specialty as pharmacists is looking at the drugs, and we take a focus on pain and concurrent disorders. So that would include mental health as well as sleep-related problems. We really take a heavy focus on safety, and that includes for people who are using opioids for chronic pain to implement universal precautions. And that's things like random urine drug screening frequently, assigned treatment agreement, limiting the amount of opioids that are being released from the pharmacy at one time as universal precautions for all people using opioids. And in terms of really just having consistent messaging going to the clients from their different care providers, we do also summarize and provide recommendations to further explore non-pharmacologic and pain education related resources. And really, we do think that there is value in our team collaborating and providing ongoing support, not only to the clients themselves with frequent follow-up, but also to the referring providers and the rest of the care team. We do really try to keep that line of communication as open as possible and make ourselves as available as possible in the setting of the COVID-19 pandemic as we're all working from home, recognizing that things come up, barriers come up, challenges come up along the way, and we are more than happy to be re-engaged in care at any point to provide some flexibility and new ideas in terms of educating and providing resources and guidance to providers and clients alike. Next slide, please, Anand. So I did very briefly touch on the referral pathways. We do have a few established pathways in terms of having a psychiatrist here in Saskatoon who is available and accessible to us on a referral basis to see our clients. Really, the role of that provider is a one-time assessment to discuss with the patient. He is currently doing virtual video appointments with our clients. And really the goal of that is to get a confirmation of mental health diagnoses or to make comment regarding the impact of the mental health on that person's ability to manage their pain, and then looping back in with the referring provider or the primary care provider to follow through on any recommendations and continue to follow those people. We also do have an established pathway for accessing cognitive behavioral therapy for insomnia, or CBTI, for our clients. Myself and our other colleague, Eric, do spend half of our time at what is the General Medication Assessment Center, and we are both trained in providing CBTI, so we do provide those services as well for the MAC iOPS chronic pain patients, as well as a registered dietitian who works with our team, and she has met with several of our patients and made comments on optimizing their diet in terms of even managing things like opioid-related side effects. Some people experience nausea, constipation, so she really rounds out that assessment and is able to provide information about managing GI-related concerns. Of course, this is not something that's new to anybody working in the realm of chronic pain. There's certainly a role, as Amy has mentioned, for the mind and movement strategies, so that being psychotherapy and physical therapies. Again, in the COVID-19 pandemic world we're living in, it's been a bit of a challenge to get those put in place for some people. We don't necessarily have established pathways to those providers in the community per se, but we certainly will do some of that exploratory work and work with clients to figure out what their preference are, what their location is, what's available in their communities, to be able to connect them with something that they can access in a timely way and that they can access frequently enough to feel benefit from it. And really along the lines of, as I mentioned in our last slide, about ongoing collaboration and care with both the provider and the client, our follow-up really is situation dependent and motivation dependent. So situation dependent being on what we actually do in terms of modifying the person's medication regimen or implementing any of the other non-pharmacologic changes. Something like a Suboxone microdosing induction, for example, we might see the patient or talk to them over video call a couple of times in that first week or two. Whereas somebody where we might be starting a new medication, follow-up might be extended out to a month. And we're looking at those outcomes and assessing change for them and improvements. And follow-up, I also think in our clinic is motivation dependent. So recognizing again that many of these clients are at different stages of change, depending on how ready they feel and equipped they feel to implement some of those non-pharmacologic recommendations, in particular around mind and movement. We do occasionally leave follow-up open to re-engage in those strategies and have discussions if people do need further support. Next slide, please, Anne. And very briefly, really this slide, I know you won't be able to see the green writing very well, but this is a clip, a screenshot from our website. And as Anand has said, the URL is available there on the screen for you. In terms of the multimedia pain I spoke about 2 slides ago, we really spent a lot of time thinking about the resources already available in the community and the realm of chronic pain management. There's a lot out there. So we tried as best as possible to consolidate what we thought might be most relevant to our cohort of people living with chronic pain that we serve. So we've got things like YouTube videos, podcasts, we've got, medication information from reliable websites, links on there, mobile apps for meditation and sleep. So really looking at this as kind of a menu of things that we can offer to our clients, and parsing through some of this and picking out what's most relevant to their situation and recommending to them has been something that we, like I said, have adopted as kind of a blanket strategy as a baseline for working with these people. Next slide, please, Anand. And as Amy mentioned, we do also provide naloxone training and are able to provide naloxone kits for folks living in and around the Saskatoon area. So we have developed some infographics that are available on our website. And again, the URL is there. So you can go to the website, you can download one side of the infographic, both sides. They're really meant to complement each other. And it really just helps people walk through the idea of naloxone being not just used for people who are using opioids recreationally, the stigmatization of naloxone for people who use opioids on the streets. We really tried to create this resource and target it towards people who are using opioids responsibly for chronic pain, and recognizing there's still a risk there associated with the use of those medications, and that risk really is compounded by multifactorial things going on in their life. So that's what this resource is for. We've used it for that cohort of people and have found that it's a really great discussion aid to open that conversation and to reduce the stigma around having naloxone in the home. All right, so I will pass it back to Amy to just wrap up and tie things together about our case conferences. And then I think we've got a couple of minutes for questions. Thank you.
It's Kelly again. I'm going to sneak this last piece in about case conferences. So I have just a minute to tell you about something that I think is really exciting and unique to the MAC iOPS program. So another part of our MAC iOPS program contribution to care is our case conferences. So Anand explained these case conferences a little bit earlier. Essentially, they offer an opportunity for physicians and nurse practitioners to meet with our clinical team to discuss specific cases. So our original intent was for case conferences to be offered to physicians and nurse practitioners and primary care providers. But once again, I think a collaborative focus has really started to emerge. So these case conferences have significant potential to bring together many members of a client's care team. And you can see on that slide there many examples of healthcare providers that could potentially be involved. We've already participated in case conferences with community pharmacists, and we're looking forward to incorporate other members of the care team as well. And I think what's most exciting is the potential opportunity to include the patient in really delivering that patient-centered approach that Taylor and Amy have referred to as well. And that is a strong focus of our program. And in the way that it takes a village to raise a child, I think that it sometimes takes a case conference to manage a complex case. So we've already provided a number of case conferences and have found that probably the greatest opportunity lies in that opportunity for discussion. So in the example of a newly inherited client on opioids, our team can help to reassess the management and maybe offer additional insight or support to incorporate change in what can be a very difficult situation to navigate. We can help apply evidence-based guidelines to your practice, offer practical safety measures to implement in applying those guidelines. A case conference may be valuable in the case of a client that isn't really interested in meeting our team or one of our pharmacists for an individual appointment, or in the case of a client that has declined follow-up. Certainly we can still come together as a team to discuss some initiatives that could still be incorporated into that client's care. And really in a healthcare environment that might leave some of our primary care providers feeling unsupported, I think case conferences offer the support to help build capacity and ultimately help change your practice. Really, primary care providers know what to do, but through our case conferences, we can help you with how to actually do that. Next slide, please, Anand. So with that, here's our team from many months ago when we were actually allowed to be within 2 meters of each other. So the 4 of us are pictured here, along with Derek Jorgensen. He's our director and clinical co-lead. Eric Landry is pictured there as well. He's another clinical pharmacist on the team. Ava Bayat is pictured. She's our administrative assistant. Not pictured are Caitlin Halpappy. She's a clinical co-lead with our team. Marissa Pirlo, our newest member and administrative assistant. And then Radhika Marwa, our team physician. So on behalf of our entire care team at the MAC iOPS, thanks for inviting us to join you today. We very much look forward to the opportunity to work with you in the future. And at this point, we'd be happy to answer any questions that you might have for us.
Thank you very much, all 4 of you. That was a great presentation. I will allow, if anyone wants, you can either unmute yourself and go ahead and ask questions, or feel free to type them in the chat box. While people are perhaps thinking of any questions they may have, I see that Angie has already added a question there, so I will put that forward. If it was mentioned that the uptake for this service has been pretty good so far, and Angie's wondering if you can provide more information about the projected need or anticipated demand for this service.
For sure. So I guess I'll answer that question. So we definitely see the need for the service to grow. We're looking at, give or take, on average about maybe 4 MAC iOPS referrals per week. Given how our opioid situation is in Canada, we definitely do see that the need for the program will grow. For that reason, and also because, as I guess the pharmacist had mentioned earlier, we just recently got permission to be on campus 1 day per week to be able to provide in-person consults. So again, the variability in virtual versus being able to see people in person will likely result in seeing the program take off from there. And the need is certainly ongoing for it as well. I hope I've answered the question.
Thank you. So as I said, if anyone has any questions, please feel free to unmute yourself and go ahead and ask, or do type them in the chat box. I'm wondering, is this, and I might have missed it, I was busy with some behind the scenes stuff at the beginning, but is this a program that operates anywhere else in the world? Like, I mean, obviously we've got Saskatchewan and Saskatoon particularly here, but was this based off of anything, or is this something that you guys might be looking to, it's like a pilot program that could grow into other provinces and things like that?
Yeah, so Jason, we're very much there isn't, I guess there is one program that might be slightly similar in Ottawa, or on Ontario. It's called the BASE, where they see patients, but it's kind of like a messenger or Skype conversation that they have with patients, whereas ours is more so, phone calls or seeing patients by WebEx. And I know I've talked to them over at the BASE, and Yeah, and they're noticing definitely the uptake there as well. And their program also targets health professionals and patients, much like ours does. But other than that, I'm not aware of any other similar programs.
That's great. Good for us here.
I think the other thing too, Jason, that's novel about our program is that it's a pharmacist-led initiative in a way. Certainly, that's not to say that we don't acknowledge the rest of the valuable input that we have from the rest of the care team, including from Dr. Marwa, our physician who consults with us as well. But it is a little bit novel in the way of a pharmacist doing that initial intake and really taking that information, starting to process it and put together an assessment to identify what we as pharmacists call drug therapy problems and start to kind of plan out a care plan, and then really integrating the input from the rest of the care team in that as well. So it's a different, a bit novel in this case.
Yeah, I really love that idea. I think, you know, as someone who's been sort of involved from a side view with, you know, interdisciplinary teams and stuff like that, I feel like often interdisciplinary teams is kind of thought of as like a physician and all the other people, right? And it's kind of nice to see, you know, that pharmacists can take a lead role in this, and other members of the team can take a lead role in terms of sort of a program type development and connecting a team. So I think that's fantastic. Are there other questions? I'll stop hogging the mic. No one jumping at the opportunity. Okay. Well, I guess we'll let everyone get on with their day. Thank you guys very much for the presentation. That was wonderful. If anyone has any questions, they can certainly email us and we can forward them on to the team. And for those of you who are regular joiners of this meeting, I believe, what's October next month? I think I am doing a talk next month, and we'll be flipping back to antimicrobial stewardship side of things. So thank you again to the MAC iOPS group, and thanks to everyone for joining us.
All right. Thanks, Jason, for having us. Bye-bye.